Hey guys. So in every section, for every type of device that you're going to use for a patient, you always want to think about what is my role as the nurse. So tonight we're going to talk about what is my role of the nurse for a ventilated patient. So first we have to understand what is mechanical ventilation. So it's a machine that actually moves oxygen in and out of the lungs and allows for ventilation. It's a support device. It's not a cure. So in other words, it's going to help my lungs to rest and it's going to do the job of my lungs sometimes, or at least take off some of that workload so that they can get better from whatever is maybe causing them to need that extra support. And it also helps to protect my airway at times that maybe I'm not awake enough or something else is causing me to not be able to protect it myself. So if you've ever heard the words intubated, vented, life support, breathing tube, these all mean the same thing, mechanical ventilation. So people that get ventilated for a few reasons. They're either not getting enough oxygen, so they're having an adequate oxygenation issue, or they have too much CO2. In other words, they're not ventilating, they're not getting that carbon dioxide out, they're not doing that gas exchange for some reason. We usually go to mechanical ventilation when no oxygen therapy is sufficient. They're on maximum support oxygen wise, and they need something more. The client needs, support from this machine until they can do it on their own, which hopefully will happen at some time. So here's some examples of people that might need some mechanical help with mechanical ventilation. People that aren't breathing at all definitely need it. Lung disease like pneumonia or other infections like ARDS, COPD, a lot of COPD patients when they have their exacerbations, and asthma as well, where their airway is closed off. So we want to have something to get oxygen in. If a patient's overdosed, has too much alcohol, too many drugs, they're not going to be able to maybe be awake enough to protect their airway, and they also can, have compromised, what do you call it, neurological status in general. That's going to cause them to be at risk for aspirating or things like that. Weak respiratory muscles. So there's some neuromuscular disorders, or, when we talk about Guillain-Barré syndrome or GBS, that can be one of the reasons why people need to be mechanically ventilated, spinal cord injuries, like I talk about there. Even people that are obese, if you remember back in adult, you learned about with obesity that the problem is that it puts extra pressure. So if I have an obese abdomen, it doesn't allow for my lungs to expand as much. That's another reason. Maybe because of my body habitus, I might not be able to breathe adequately or ventilate. And there's other neurological disorders or trauma. If the airway is closed, if I'm very agitated, maybe going through alcohol withdrawal or delirium tremens. So there's a lot of different reasons that patients can need a breathing tube. And most of these are reversible, or at least we can get them to the point where they won't always need that breathing tube. So as the nurse, I need to watch out. One of my main roles is watching out for complications. So a couple of complications to know about is first, when patients are on the ventilator, they get what's called PEEP. And if you don't know what that is, in my other YouTube video, it explains a little bit, and I'm sure you'll learn about it in class. But PEEP is something that's going to help keep those that place where oxygen exchange happens, or your alveoli, keeps it open. The only bad thing is because it keeps it open, it hyperinflates the lungs, and that actually makes the lungs kind of like, think of someone like with a real strong barrel chest, and it keeps everything open. But and I don't want to say barrel chest like they actually have a barrel chest, but you know what I'm saying is that they're expanded, and so because of that, that actually puts pressure on my blood vessels that are in my chest, including my aorta, that that is returning blood to my heart. So there's decreased return of blood to my heart. And what do you guys remember? Because you guys have done cardiac. What do you guys remember about decreased blood return to my heart? If I'm not getting blood back to my heart, I don't have as much volume or preload to go out to the rest of my body. So I'm going to have decreased cardiac output. So if I have too much PEEP, or if I turn up that setting to help them oxygenate more, it's going to put pressure on the blood vessels in their thoracic cavity or their chest, and it's going to cause a decreased amount of volume back to the heart. Therefore, there's less blood, less cardiac output, less perfusion as a whole. Patients can also have complications during intubation. So, in other words, sometimes the drugs that we give them, they can cause hypotension. When we intubate them and they have that breathing tube in, they can also have complications from the tube itself. So they can have breakdown on their lips, here where we keep the device, or if they use tape kind of around here. We also need to look on the back of the neck for the devices that go around the neck to hold that tube in place. But we always want to be looking for breakdown. There's lung complications, and so there's what's called barotrauma, and then there's volutrauma. When you think barotrauma, think balloon pop or too much pressure. And so effectively, barotrauma would be like we're forcing oxygen in a patient in this ventilator. Normally, naturally, nothing's forcing oxygen. We're not using a machine to push oxygen into ourselves. Naturally, because of the way the pressures work in the atmosphere, oxygen naturally goes in, and then I use my respiratory muscles to ventilate that CO2 out. But when we're using a mechanical ventilator, it actually forces that air in, and that extra pressure, that extra push, and that expansion, that volume that we give a patient when we when they are mechanically ventilated, it can cause too much pressure, and it can end up with like a pneumothorax or like a balloon pop, as we say. There's also volutrauma, and that's because we're also giving more volume than what maybe the patient's used to. They're getting extra oxygen, again that extra push. So think of the alveoli sweating. There's so much extra volume or push down on the bottom of those alveoli that they can actually start leaking, and they can get like pulmonary edema or difficulty breathing. But if you're getting confused between the two, just know as a whole, ventilators create more pressure, which can cause your lung to get punctured like a pneumothorax, or it can also cause you to fill up with fluid in your alveoli, which is where you're going to need to do oxygen exchange, which can make it even harder to breathe. You also have to consider complications of immobility. We're going to talk more about these, but musculoskeletal, gastrointestinal complications like constipation. Also, they can get tube feeding and get diarrhea, lots of them. And then skin complications, they're not moving around. With musculoskeletal, you also have to consider they're higher risk for blood clots, DVTs. And so they're going to definitely need a lot of prophylaxis and prevention from the nurse. And another one that's maybe commonly forgotten is psychosocial and delirium complications, where these patients, they can sometimes not be the same after because of the medications they're on long term, sometimes if they have to be intubated for a while. So that's why it's really important as the nurse to kind of watch for these things and try to support the patient. So what is my daily care for an intubated patient? I always start at the patient, and then I make my way to the machine. I never want to start with the machine. The machine's not going to tell me how the patient's doing. So I want to start at the patient. Some of the things I'm going to look for, and this is in no particular order. I'm going to, look to make sure the tube's in the right place. So every day when I get reports, the nurse is going to tell me, hey, you have a breathing tube. Here's the size, and then here's where it's at. And they're telling me where it's at the teeth. So wherever the tube is marked at the teeth, and if they don't have teeth, it's at their gum. That's what I want to know. And I want to make sure that it's in the same place that the nurse before me said it was, to make sure it hasn't come out a little bit or gone too far in. I'm also going to move the tube to prevent skin breakdown. Like I said, there can be breakdown. So they actually have this cool device that I can move it side to side and in the center. And so usually we like to do that every 2 to 4 hours to prevent skin breakdown. I'm also going to, of course, check all around the device and around their neck for other signs of skin breakdown as well. I want to do a good neurological assessment. Are they awake? Are they able to respond? Because I want to get this tube out as soon as possible. I need to see where they're at. And in order to get that tube out, they have to wake up a little bit for me to be able to help them. I also want to check if they're attached to any medications. Again, I'm going to start with the patient, but I'm going to make my way also if they're attached to any medications. I need to see what is their sedation. And we'll talk about a sedation vacation here shortly, but we pretty much want to ensure that we keep them on as minimal sedation as necessary to prevent complications. We also want to listen to their breath sounds and see what their breathing effort is. How are they tolerating the ventilator? Is it helping? How is their breathing? How are their lung sounds? Do they need to be suctioned? Then I'm going to kind of move away and like start to kind of check, okay, is the device in the tube secure? Is there a facial device that's holding the tube there? Is that secure? Are all the tubes connected? Like I said, I might suction the patient, especially if they have coarse lung sounds, but I want to see, do they have a cough and a gag reflex? What's coming out of them? Do they got really thick stuff? Do they have a lot of secretions? Not a lot of secretions? Do they wake up when I suction them? Oral care is key too. So, every procedure or hospital might be a little bit different, but usually we do it about every 2 to 4 hours. And so, as a nurse, I do it every 4 hours, and then I go opposite the respiratory therapist. So they do it, and then I do it. So it ends up being about every 2 hours. But we need to do that a lot because they have something that's not theirs in their mouth, and the mouth is a disgusting place. Hate to tell you, if you think your mouth is beautiful and pristine, it's disgusting. So we have to wash that out and make sure to try to prevent, ventilator associated pneumonia, which we'll talk about here shortly. Keep their head of bed elevated. That's going to prevent aspiration. It's one of the most important things to help to support them so they do not get ventilator associated pneumonia. And then I'm going to be at the machine and I want to know what their settings are. Are they on a lot of support or not a lot of support? Are we trying to get this tube out today? Or are we just trying to support them? How can I help this patient today? What are their goals? And so that's going to be individualized to each patient. So we're talking about VAP, or ventilator associated pneumonia. So this is kind of like a pressure injury or a central line infection, or what do you call it? A catheter associated urinary tract infection. Like, we really want to prevent this from happening. Of course, hospitals want to get paid, but at the end of the day, we really don't want that to happen to a patient. So ways that the general guidelines to prevent ventilator associated pneumonia are going to include minimizing sedation, getting the tube out as soon as possible. So in other words, if they don't need it in, let's not keep it in long term. And we're also going to do what's called sedation vacations. And that means at the beginning of my shift, I'm going to go in and turn my sedation off. And then I'm going to wait for the patient to wake up. And trust me, they're going to wake up. There's very rare patients, unless they have a severe neurological deficit, that won't need some sedation, because breathing through a breathing tube like being intubated is like breathing through a straw. It's very uncomfortable. So when these patients wake up, you don't want to turn their sedation off and walk away. Most of the time I got to stay in the room because they're probably going to wake up with a fire and be like, what is this? I can't breathe, and get very upset. So when they start waking back up, then I'm going to turn that sedation back on at half the dose that I was on before. Now, I don't know what your textbook says exactly about this procedure. This is JPS's procedure, but I usually start at half the dose, and then I try to be on as minimum as possible. And that helps to get them to a point where they're just getting exactly what they need, not having too much. It's always about a balance with sedation when someone's on the ventilator, because we want them to have enough where the ventilator can do its job, and they're calm enough where the ventilator can take away that work. Like, if they're not enough sedation, they're going to be breathing fast, freaking out, and working themselves out. So it has to be a balance, but again, we don't want too much. We also want early exercise and mobility, so doing passive range of motion and trying to move them around is key. We also want to, if possible, use tubes, those ET tubes or those endotracheal tubes. There's some special ones that have a suction port that goes into the back of your throat, right on top of the balloon that's in the endotracheal tube, and it suctions the back of your throat pretty much. And that's really helpful because, remember, your mouth is a disgusting place, and so it kind of sucks up some of that bacteria that might be getting stuck down there by that tube that could slip into your lungs and cause pneumonia. Like we mentioned, head of bed elevated 30 to 45 degrees, and that we shouldn't routinely be changing that tubing. When I'm following that tubing, I should not be disconnecting that tubing anytime. We want it to be a closed circuit, or pretty much once we attach it to the patient, we're not opening it again until that tube's out, because we do not want to open it to the air where any bacteria can get into it. So kind of think of it, we're trying to keep that inside of that tube sterile. It's going straight from the machine to the patient, nothing opening or getting in the way of that. So another part of my role as the nurse is to handle ventilator alarms. So there's three types of alarms. There's high pressure, low pressure, and apnea. And I always tell students, like, these are where I see a lot of HESI NCLEX like questions, and I guarantee you're probably going to have at least one question about this on your exam. And I don't say that because I know it's on your exam, but I say that because this is something that's very common that you're going to have to do as a nurse, and it's really important to be able to differentiate these. So I definitely recommend writing these out. So when we think about a high pressure alarm, this is the machine telling me something is blocking me from being able to get air in. There either is literally a blockage, like a kink, or there's something in the way that's causing resistance. So kind of think of this like Systemic vascular resistance from cardiac, like there's too much resistance. The tube is ventilators having to overcome too much resistance to get air in. So this might be because the patient has a lot of secretions. So kind of think about like COPD and asthma, how they have all those secretions in their breathing tubes, and that it's really hard. There's a lot of resistance, so they struggle, to get enough oxygen. And so the patient could also be coughing, and that's going to be counter pressure. It's like they're coughing and then it's trying to push air in, and they're meeting there in the middle. And that can be difficult for that patient. And it could also be the patient's waking up and fighting, biting on the tube. Maybe there's a kink somewhere. They might be breathing asynchronously because they're freaking out because they're like, I'm breathing through a straw. And then also what we call decreased compliance. And that means that even if, let's say, there's no secretions and the patient's not fighting it, there's no kinks, but what if my lungs are just really stiff? And so if this ventilator is trying to push in oxygen and my lungs are just like, I'm not moving, buddy, like, there's no way that I can get that oxygen in. So that's why you can have high pressure alarms. Those are some of the common reasons. There's also low pressure alarms, which means a disconnection. So this is the opposite. Before there was too much resistance. With low pressure, there's no resistance. Something's open or disconnected. So this happens when the tube gets disconnected. So if for some reason the tube gets disconnected from the ventilator, that can happen. Or if the patient pulls the tube out, or if there gets a hole in the tube, which can happen because there's a balloon when we insert the tube, we inflate a balloon, and that can get a hole in it. And this can all lead to a low pressure alarm. So in other words, high pressure, resistance, blockage; low pressure, disconnection or leak. There's an issue with not enough pressure. There also can be apnea alarms where there's no breath. So this can be maybe the patient's had too much sedation. Maybe they're stopped breathing altogether, they're respiratory arrested, or maybe a change in their condition. Maybe they had some sort of injury or neuromuscular issue where their diaphragm stopped moving. So as a whole, we just want to make sure that we're supporting them when these alarms come on. Usually the first thing we want to do with these alarms, and you'll see this a lot in practice questions, is that we want to disconnect them from the ventilator and manually bag them. In other words, I'm not going to sit there and take a bunch of time to be like, oh, okay, what's going on? How's the patient doing? Let me check on some things. Let me, do all this stuff. I want to make sure the patient's getting enough oxygen. So I'm usually going to use one of those squeezy bags and squeezy bags, bag. I should use the official names: bag, valve, mask, kind of thing. Not mask. It attaches straight to their tube, and I'm going to just squeeze it to make sure that they're getting 100% oxygen until I can figure out where the problem is. Maybe the problem's them, maybe the problem's the ventilator, but until I find out, I don't want to sit there. If their oxygen saturations are going down and they're really unstable, I'm not going to sit there and play it by ear. Now, if I just go in, my alarm's going off and they're stable, everything seems okay, but there's just something beeping. Okay, well, let's figure out what's going on. But if I go in, the patient's not breathing well, they're going crazy, something's not working, I need to manually, ventilate them until we can figure out what the problem is. But yeah, so my job is really just to assess and kind of find out where the problem is. Is there a blockage? Does the patient need to be suctioned? Do they need more sedation? Or do I just need to reconnect something? Is there maybe just something that got disconnected? And usually you can tell there's a lot, you'll hear like a really loud, like air, like, shh, like, and you're like, oh God, I'm disconnected. And then of course, apnea, it's going to tell you, hey, they're not breathing. And you're going to look at your respiratory rate and be like, yeah, the chest isn't moving. And so as a whole, it's just about kind of looking at what the machine is telling you, but then looking at the patient. Always start at the patient and move to the machine. So I have this guy here, and I can kind of minimize this real quick and kind of get here. So, because I want to kind of tell you about, like, there's a lot of complications that can happen. So when I do a head-to-toe assessment on a patient that's on a ventilator, I need to make sure that I am covering everything. So I'm going to just point to a couple things here. So we're always going to start maybe, I always like to start at the head for any patient. I talked to you about some of the stuff I'm going to look at with the tube and stuff, but I'm talking about how are we going to assess for complications of mechanical ventilation? So of course, I'm going to start with the brain. What's going on? Is there any delirium? Decreased, what is their thinking process? Are they able to understand me? Do they wake up? Do they follow commands? Where's their neurological status? Because I want to know how they're doing neurologically, because otherwise I'm not going to be able to get that breathing tube out if they can't follow commands or don't have the ability to keep themselves awake. I also need to, of course, be checking their skin for all those devices they have around their face, making sure there's no skin breakdown around their mouth or around their their neck. I'm just sitting there thinking the eye. So they all have this breathing tube here. And so I'm going to check around the skin here and be looking for all of those, that possible breakdown. I'm also going to assess for fluid balance. A lot of patients can have fluid and electrolyte imbalance when they're immobile in bed. So I'm going to be looking for any jugular venous distension or signs that they're holding on to more fluid there. And as I go down, of course, I'm going to look for edema in other places too. So, like I mentioned, there's cardiovascular complications, and so I want to assess what's their blood pressure. How are they tolerating that? Do they have too much pressure going on? I want to do a very good lung assessment and make sure that they're not showing any signs of those complications from, the barotrauma. Do they have any signs of subcutaneous air or pneumothorax? Do they have any signs that they're not breathing adequately? Does this seem to really be helping them? And so doing a really good lung assessment and not just, listening, but looking, what's their respiratory effort? And then additionally, I want to see how their perfusion is going. The whole point of mechanically ventilating, I told you, it could be a ventilation problem or it could be an oxygenation problem. But as a whole, a lot of times these patients are not getting good perfusion to their tissue. So I want to be checking their, pulses and their capillary refill and seeing what's going on. How are they perfusing? I also want to be doing some range of motion exercises with them to make sure that they're getting, they're not losing their strengths or getting contractures. So there's also my abdomen. So with my abdomen, I want to make sure to try to feed this patient early. There's a lot of studies that show that it's one of the most crucial things is to get the patient started on feeding very early, because if I don't get them fed, a lot of times they don't get the nutrition that they need, to support them. And so my job is not going to be just to make sure that they're fed, but to also prevent complications from that. Fluid and electrolyte imbalances, make sure they're getting enough, make sure I'm not putting their head down, and that they're aspirating that tube feeding, make sure that their feeding tube is in a good place, all that stuff. So that's going to kind of add to my role. I also, it's not drawn here, but I need to check on the kidneys. The kidneys can have injury from mechanical ventilation or if there's any sort of dehydration. Remember, I talked about the possibility of having decreased cardiac output or decreased blood pressure, hypotension. So because of that extra pressure from the ventilator, well, I need to check the kidneys. Remember, the kidneys, they're very selfish. They want their perfusion. So I need to check and see how they're doing. I also need to make sure that what's my urine output? Is the patient peeing? And most of these patients may have a Foley catheter, but a lot of them are going to maybe have, like if they're male, they might have a condom catheter, or females can have pure wicks. They might just be okay with being incontinent. So I need to check their skin. As I'm going through, I need to be looking at their skin. Is there any breakdown or anything else? What do you call it? Make sure that I'm keeping them clean and preventing infection. Then I'm going to check their legs and I'm going to look for edema. I'm going to be checking their perfusion, looking in their feet and their toes. And I want to do good range of motion. They're also going to be at risk for foot drop. So I want to make sure that they maybe have those boots that help to keep their foot in a normal position, keep their foot upright. And make sure that I'm kind of working with them. A lot of times physical therapy and occupational therapy will work with them as well. And we also try early mobility. If we can get them up out of bed or at least sit them in a chair and they're awake enough for that, we definitely want to do that. So this is a lot of what, that you're assessing for complications. You're not just assessing for the problem they have, you're also assessing to see, how's this mechanical ventilation going? Is it causing more harm than good? And even if it is causing more harm, it doesn't mean we can say, let's take it out, but you still want to see like, how is the patient affected by this? So as a whole, you really want to, do this head to toe. And this would be a good activity to maybe do with your study group or by yourself, where you kind of print out. I have this, what do you call it, this on my Google Drive. It's just a human body infographic, but you can also just draw a stick figure on a piece of paper. How does being intubated affect every part of the body? And what am I going to assess for? And what interventions am I going to do to help support it? But yeah, hopefully this is a good start for you to get started looking at care for the mechanically vented patient. And I will see you next time. Bye.